So today we're going to be going through, we're going to meet a few people who've been working on recommendations for how social prescribing can be supporting refugees, asylum seekers and people with refugee status. Doctors of the World have an amazing toolkit. They'll be presenting on that. We're going to hear from a couple of organisations that are doing specific work around it locally, and an organisation who we think will be really relevant to you as link workers to be referring on to. As I said before, hopefully this will spark some inspiration and examples. There may be examples or that you want to share, or cases actually that you want to bring to the people that are presenting today. We're going to have everybody around until 2:30, so there'll be an opportunity to ask questions later or bring some cases to the group. Let's kick things off. You don't need to hear from me anymore. I think we've got a good amount of people in the house, so I'd like to introduce Claire Zhang. She is the National Migrant Health Lead and Inclusion Health Officer at Public Health England. Her team developed national guidance on the health of migrants and other socially excluded populations. She's working in partnership with government departments, the NHS, third sector organisations and academic institutions on a number of policy, research and workforce development projects. And as an aside, this is a subject, it's clear in the meetings we've been having planning this session, it's a subject she feels very passionately about and knows a lot about. So any questions, chuck them in the chat and I'll hand over to Claire.
Thank you so much, Leanna. And it's so great to see so many of you here for this session. Can I just check that you can see my full screen that I'm sharing?
Yeah.
Perfect. All right, I'll get started. So today I'll be sharing, two things. First of all, I'll be sharing the findings from Public Health England's recent evidence review on social prescribing for migrants. And then I'll be going through some of the recommendations on the new social prescribing page that some of you may have already seen on the Migrant Health Guide on gov.uk. And I really love to thank all of these people who are involved in the evidence review and also the development of the guidance that's recently been published on this topic. And I know some of you who are on the call probably have worked with migrants for a very long time and really understand why it is that sometimes migrants' health can be quite different to that of the UK-born population. But for those who might be new to this area, I just wanted to really quickly go through some of the factors that shape migrant health. And just thinking really about the country of origin for migrants before they come over to the UK, there are factors like disease epidemiology and also the conditions back in their country of origin, as well as their access to healthcare that already shape their health prior to their migration journey. And then along the way, we know that there are different reasons for migration, some voluntary and some forced, and other circumstances that shape their health and well-being way. And also being really conscious of the break of social ties that happens as well when migrants migrate to a new country. And when they arrive at the destination, there are factors like their legal status and the current migration policies that have an effect on their health, as well as some of their living and working conditions, and also things like cultural and language differences, and of course not forgetting experiences of exclusion and discrimination that also have a huge impact on health and well-being. So keeping all things in mind, Public Health England really wanted to really understand and describe the evidence base for social prescribing for migrants in the UK. And we really wanted to look at three things. And one of those things was, well, what approaches have actually been evaluated for social prescribing for migrants in the UK? The second is, well, what are their effects on migrants? And rather than just focusing on physical and mental health, we also wanted to have a look at things like, does social prescribing change the way that migrants use healthcare services? And does it impact on other things like their self-esteem and their confidence, even things like social connectivity? And then finally, we wanted to learn about the experiences of how social prescribing services are being implemented in the UK from the perspectives of, migrants, of the providers, and also the referrers as well to social prescribing programs. collected our studies, our articles by two different methods. The first one was doing a database and a grey literature search. And we looked at studies from the year 2000 up until the middle of 2020. And we wanted to capture a broad range of different study types in our evidence review. You know, as long as there was one migrant in the sample or the cohort, we accepted that study for inclusion. And social prescribing, we kept the definition quite broad too. So any kind of approach that involved a sort of intermediary or a coordinator that linked migrants to a final prescribed activity. I knew that we probably wouldn't be able to find too many studies like this, because we know that studies in social prescribing are quite rare anyway, even for the general population. So we supplemented it with a call for evidence for about 4 months last year. And we got about 25 items that were relevant to the UK that were submitted through that call for evidence as well. And you can see from the thousands of studies that we had from the beginning that we screened, we ended up whittling it down to only 32 studies that we could include at the end. And I just wanted to briefly talk through some of the findings. And I'll go into, I know it's ant size, right, probably on the right hand side in the diagram, but I'll zoom into it a little bit more soon. But quite broadly, in terms of social prescribing approaches, we found from our review that approaches varied very widely across the UK, and there was a huge breadth of prescribed activities as well. We also interestingly found social prescribing link workers quite often took on additional roles in addition to being that link. And this is something we'll touch on a little bit more deeply. And so just zooming into the diagram on the right hand side, you'll see that there's quite a number of different types of referrers that help to bring migrants into social prescribing programs via a few different types of entry methods. And then you can see down the bottom that link workers, we sometimes found that link workers played that single function kind of role, but a lot of the time they also provided those prescribed activities themselves, or they had other roles alongside. And sometimes they weren't necessarily called link workers, even though they did a linking kind of role. And, you know, they may have also been a caseworker or an advocate or, you know, a linguist as well alongside. And then there's a huge number of prescribed activities, the breadth, and I haven't even captured everything that we found in this, but you can see that there are some activities that are very specific to migrants, like immigration-related support, language and cultural support. But interestingly, for the general population, we often found that, you know, that individuals were referred to social prescribing programs from mainstream healthcare services and then, you know, linked out to prescribed activities. But for migrants, sometimes it was the other way around, that they came in via the third sector or self-referral, and it was actually the link workers that linked them back in to mainstream healthcare services. And this is something that my colleagues, Kemi and Yusuf from Doctors of the World, will be touching on specifically in their presentation. In terms of the effects of social prescribing, it was interesting that the most frequently observed effects of social prescribing was actually not health and well-being, but it was actually on these other health and well-being related outcomes like self-esteem and confidence and social connectivity. We found very anecdotal evidence of improved health and well-being, but not very specific measures of that. And similarly, there was a lack of measurement too on the impact of social prescribing on healthcare use as well. And I'll touch on that in a bit more detail when we talk about the quality of these studies. When it came to the implementation of social prescribing programs, we sort of grouped these into 5 different themes. So we found that, you know, whether it was migrants or providers or the referrers to social prescribing programs, that they touched on service access when talking about implementation. They also touched on service resourcing and coverage and funding shortages, and also gaps in service delivery was mentioned quite a bit. When it came to the service delivery aspect of things, the responsiveness of services to cultural differences and also to individual preferences was often mentioned. And there was also this issue about blurred boundaries, which, as Leanna mentioned, it sounds like you actually have a webinar coming up about this very topic. And then when it came to service capability, some link workers found that they felt that they didn't have enough knowledge and skills, but others felt that they had actually developed their skills and also, received training along the way when it came to migrant-specific health issues. And then there were external considerations like whether or not, local regions and healthcare services were actually aware of the types of social prescribing programs that were available to refer to in the region. And also there were considerations like hostile environment policies. So being able to actually provide services where they were needed when, migrants were moving around and being dispersed, and it was quite difficult to catch them or to ensure that they were ready for the services. And I think to caveat all of the findings, unfortunately, there was quite low internal and external validity of the studies that were included in the evidence review. And that was because of the fact that in this area, we know for social prescribing in general that there's quite poor quality data out there. And also there's a lack of robust evaluation methods. So often we couldn't tease out the effect of social prescribing from other broader interventions that were sort of a package deal in a lot of these studies that we looked at. And also kind of these programs on migrants versus the general population, when you had everybody all mixed in, there wasn't very specific findings necessarily to migrants themselves. Sometimes it was about everybody who was in that program. And there was a lack of sort of recording of migration-related demographic information for clients as well. And we'll get to that a little bit later. But onto probably the more exciting part, which is the new social prescribing page. We wanted to use all of the findings from this evidence review to inform the development of this page, and we have. So there's a link on this slide to the page, and I wanted just to take you through the recommendation section of that and also hear your thoughts as to whether these recommendations are feasible and what they would look like in practice. Decided to break up these recommendations into the audiences that we would be making these recommendations to. So when it came to referrers, our recommendations were really that, you need to be aware that migrants may require a greater range of prescribed interventions or activities than the general population. And also that referrers really should have some kind of way to systematically record social prescribing referrals and activities in electronic health records or whatever other records that they have, because this really would support better and more routine monitoring and evaluation of social prescribing. The bulk of these recommendations are for link workers. So in this particular section, we sort of broke it up into recommendations for link workers before they actually come into contact with their migrant clients, and also what they should be doing during. And the before section really is a lot of signposting to different resources to help them to develop knowledge in things like migrants' entitlements to healthcare, because that quite frequently comes up as an FAQ, and we've got resources in the recommendations to link you out to those bits of information. And then there's things like how to support migrants to access mainstream healthcare services, which Yusuf and Kemi will touch on soon in their presentation. But there are also signposting out to resources like, learning more about the wider determinants of migrant health, and things like trauma-informed approaches to service provision, which I think was one of the questions that was raised in the sign up to this particular event. So there's links to information about that as well. And while link workers aren't, dealing with the medical side of things, they also should be broadly aware of the risks of, for example, communicable diseases or non-communicable diseases as well, that may affect migrants' health and well-being. As well as things like safeguarding and also looking after their own health as a service provider. During the session, these recommendations that we've made are very much based on the findings from the evidence review, where social prescribing providers said that they had the most success when they had these really tailored conversations with migrant clients about exactly how they would want these sessions to be delivered. And the main sort of factors that they had these discussions about were things like, language and culture, and would you like link workers of the same sex? Or when it came to prescribing activities, is it going to be same-sex groups or mixed-sex groups? And also things like considering service delivery format and whether that person actually wants very personalized care or if they just want some quick signposting. So essentially not taking a one size fits all kind of approach when it comes to the migrant population, but really individual conversations that I had. And then this topic about role boundaries really came up again. About what do you do when there are gaps in service provision, but you don't know where your role boundaries lie in terms of just linking migrants out to support or actually taking on more of a role in providing those services. And I'd be really interested to hear all of your thoughts and what your experiences are about this later on. And then considering that access to healthcare is a really important part of workers' role when it comes to the migrant population. And also considering what's the best window of opportunity for service provision for some of these vulnerable migrant populations when you really need to be ready to problem solve changes and anticipate changes to things like migrants' housing or their legal status or moving locations, and also their readiness to engage with services. And then in the Migrant Health Guide, we've also provided some recommendations about monitoring and evaluation. So for those who are, commissioning services or have some role in planning them or managing these social prescribing services, making sure that these programs aren't just funded just to run and be implemented, but also have funding available for really robust evaluation so we can learn about what works and why. And then using things like comparative designs too, which was quite missing from the evidence that we reviewed, is that it wasn't really possible to compare social prescribing or to compare migrants to non-migrants because this wasn't really built into the evaluation of these services.
Claire, could you, this is amazing. Would you mind, someone's just asking if you could clarify how you define migrant in this context?
Yeah, sure. So in this context, we kept it very broad. So anybody who had any kind of international migration across borders over to the UK. So I think the definition we used was from the International Organization of Migration. So that's migrants, refugees, anybody who had come over for any reason and for any period of time. I hope that helps.
Great, thanks.
No worries. And I should actually mention that the majority actually of studies that focus specifically on migrants, they actually focused on refugees and asylum seekers. So when there were a lot of studies that mixed in, migrants or didn't really define what they meant by migrants, specifically in terms of migrant groups, but those that did very specifically talked about a lot of the time refugees and asylum seekers. So these findings are relevant. And then going back to the recommendations for evaluation, data collection was quite an issue. So as we just touched on, people didn't really define who their migrant groups were a lot of the time. So actually being able to improve the collection of data on things like knowing about their country of birth, the type of migrant, their migration history and their languages spoken would really help evaluation and also research in future. But it's really important to note that, there's this fear of data sharing between Home Office and NHS services. And so it's really important that trust is really built when asking questions like this. And there's a link here to guidance as well in the Migrant Health Guide that can hopefully inform social prescribing link workers on the circumstances in which data is shared between Home Office and NHS services, or circumstances in which data can be shared, to also understand what those circumstances are and be able to inform migrant patients about this before you start asking questions about their migration history and immigration status. And recommendations here, I'll just quickly whiz through this, but in terms of there's a framework for measurement social prescribing outcomes, and also being able to capture referrals and things like healthcare utilization, consultation rates that have potentially changed as a result of referring out to social prescribing services. And we've also recommended for researchers that actually validating some measurement tools would be really handy for not only social prescribing, but for social prescribing for migrants in particular. And it would be really helpful to understand in future why it is that link workers take on additional roles when providing services to migrants. And maybe we'll have that discussion today as well to learn a bit more from you. But because, you know, there is this question that goes unanswered about, is it actually this sort of single function link worker role that's most helpful for migrant populations? Or are we actually seeing that those more broader transdisciplinary roles that capture a little bit of everything is more helpful for complex cases when working with migrants? So that remains a question to be answered. So I'm not sure if we have time now, if we want to say this till the end, but whenever we have this conversation today, I'd really love to hear from you, you know, whether what we found in the literature matches what you're finding in practice, and also learning a bit more about, you know, the challenges that you've experienced supporting migrant communities, and even what works as well, and some of those topics that were highlighted, like taking on additional roles or even navigating role boundaries, and also hearing about what your take is on sort of the feasibility of these recommendations that we've made as well. Thank you very much.
Thank you. That was really, really wonderful to hear from you. And I think I'm sure that I couldn't see everybody's faces around the room, but I'm sure there's probably lots of nodding going on with lots of the things that you're saying. I definitely think we can come back to discussion later, but are there any comments from the room around, I'm just looking to see who I know has been working with link workers. Esther, did you have any thoughts on Claire's presentation at all?
I thought it was brilliant. Thank you, Claire. Yeah, really pertinent, everything you said. It's quite nice to hear it said out loud about the additional the additional role. Yeah. So probably from my point of view, when I started a year ago, I'm only part-time, but we, from the beginning, allocated at least, well, it's hard to define, but at least half my hours are now with my community. Yeah, I could go on, but thank you, Claire.
Thank you, Claire.
Anybody that didn't agree with what Claire was saying, or felt that they couldn't no, looks there you go. You've done the research is on.
Thanks,
we got one question that went unanswered from Deborah. Who were the link workers employed by in your review?
Yeah, I just saw that. Thank you, Deborah. I whizzed through that the slide about the initiator role, so the who referred into social prescribing programs, but also I guess the link workers themselves. Are you asking about? So you said who were the link people employed in your review? Is that specifically asking about link workers? Who were they employed by? Oh, I don't know if Deborah's there.
Yes, it was. Yes, it was. I didn't want to call them all link workers because, as we know, they have a variety of different titles. But yeah, the person who's doing the linkages, who were there, typically who were they employed by in the studies?
Yeah, so a lot of them were employed by NGOs or by services that were commissioned by the NHS, but there was a huge variety in terms of where these were coming from. And I think because of the fact that a lot of our studies came through the call for evidence as well, potentially, you know, we had a little bit of bias in terms of what was coming into us because it was the people who, you know, we managed to reach through this call for evidence as well, the types of organisations.
Elizabeth's got her hand up. Elizabeth, are you a link worker in London?
Yeah, hi. Yeah, hi, this is Elizabeth. No, I'm not a link worker, but I have a small charity that I've set up to assist, well, generally BAME, even though we're not supposed to use that word anymore, but I've had 25 years of experience with refugees, and I'm currently rebranding my organization to include refugees. And my question is basically two questions. First of all, the confidentiality aspects, because I know from my own sort of experience working with refugees that that's one of the main sort of underlying concerns as to who gets hold of the information regarding their life, their journey, their family, and so on. And then secondly, is there a program to assist link workers in understanding the culture behind migration, for in terms of contemplative-based practices, for example, that holistic aspect that you spoke of, Claire, meditation, sound therapy. Is there a program that would assist link workers to recommend those type of trauma-informed interventions? I hope that's clear.
Yes, that is. Thanks, Elizabeth. To touch on the first point you made about confidentiality, unfortunately, our full paper isn't published yet to share, but once it is, we can definitely share it with you. There was a little bit of, I think in some of the studies, they mentioned confidentiality, and there were some suggestions on, different strategies to get around it. So, for example, sometimes people talked about trying to find link workers that were outside of small, especially small minority ethnic communities or small refugee communities, and being able to offer a choice of link workers in order to maintain that confidentiality. More generically, we have guidance on the Migrant Health Guide about things like ensuring confidentiality through choice of interpreters as well. And being able to use professional interpreters, for example, rather than family members. So for specific aspects of service delivery, there are those kinds of strategies that you'll find on the social prescribing page. There will be links out to those. In terms of resources specifically about the cultural considerations, we have generic guidance on the Migrant Health Guide, not specific to link workers, but about how to consider things like culture, spirituality, religion. And we're actually about to update that page with fresh resources as well. So there may be some things that are relevant, but maybe I can hand over to some colleagues as well on the call who might have recommendations.
I was just thinking, what a great segue. Thanks so much, Claire. Claire's going to stick around, so we're definitely going to have some, if there's some cases or some further questions later, then I'm sure we can go back to Claire. We're going to hear now from Kemi and Yusuf. Kemi's, they're both from Doctors of the World. Kemi is a national health advisor, and she led on the production of their new social prescribing toolkit, and that's designed on improving access, designed to support link workers to improve access to healthcare for migrants. She's also working at a social enterprise called Love Welcomes that help refugee women get into employment. Yusuf, who works alongside her, leads the participation work and coordinates policy programmes to ensure inclusive access to healthcare for asylum seekers, refugees and marginalised migrant groups. Both, again, doing some amazing work. So let me bring in the two of you and hi.
Thank you very much. Can I just ask if I can share my screen so that I can?
You should be able to. Yeah.
Just a second. Thanks, Liana, for introducing us, and hi everyone. It's really great to be here, and so many participation and lots of good questions as well. So as Liana introduced, I'm a policy and advocacy manager at Doctors of the World. We have been commissioned by Mayor of London in springtime to do a toolkit and some materials to help social prescribers for their work with migrants. So that's what we are going to be discussing, and actually kind of providing an overview of these materials today with my colleague Kemi. I am leading the participation work with service users and migrants who are benefiting our services at Doctors of the World. So we have a group of experts by experience who are called National Health Advisors. So we were very closely working with them, and Kemi has led this work on behalf of National Health Advisors and has kind of produced this research together. So just to say, Doctors of the World is a medical charity. It's an NGO providing health support and advocacy services for people who don't have access to mainstream health services. We have a clinic in Stratford. That's where we actually help people to register with a GP. But we have been already delivering social prescribing services ourselves. We don't call it as social prescribing, but we do a social assessment of all patients we see, and we refer them to appropriate services. So we have a bit of a practical knowledge as well, but our main aim in this project was actually really to support link workers like you to actually go step by step in understanding how you can ensure your migrant patients have meaningful access to healthcare. So I'm going to hand over to my colleague Kemi now to introduce the project, a bit about the project, and then I will take it from her to actually look at the resources together. Kemi.
Thank you, everyone. Thank you, Yusuf. My name is Kemi, and I'm one of the National Health Advisors, like Yusuf said. And now I'm going to talk about a little bit about the documents that the guidelines we made. After the call, the Public Health England call, there have been some consultation on how social prescribers can support migrants. And we found out that there are two gaps, and those gaps are lack of knowledge about the NHS entitlement for migrants, and also that there are some barriers that social prescribe, there are some barriers to access social prescribers by migrants, because migrants can't access, they can't access GP. Because of those gaps, that was the reason why we produced this material for link workers. And we all know that most of the barriers that migrants have, or if you don't know, these are most of the barriers that migrants have and for them to access GP registration. And Doctors of the World have been able to help most migrants to register for GP. Even with that, you can see even Doctors of the World helping migrants to access GP, they still refuse 19% of them. And this is some of the barriers that migrants are facing, which is lack of ID or proof of address, also their immigration status, and most of them are scared of arrest. They have the fear that their data will be shared with the Home Office. A lot of migrants have language barriers because they don't speak English, and they need somebody to interpret for them. Also, digital inclusion, most of them don't have enough data. You know, everything is going online now. And also the fear of secondary charges for fear of charges for secondary care. And doing our, developing our resources, we did some researches, we did some depth researches, and then we did some consultation with some social prescribers and some migrant, and also my fellow national health advisors. We did some, we got some feedback. Some of our findings include that we know that link workers can play important roles because they provide personalized care to people they support. And we also find out that many migrants are not even aware of what the term social prescriber mean and the service they provide. And also find out that further trainings and resources on immigration status and entitlement to health care can help link workers, because not all link workers knows the difference between each type of migrants that we have. And before I pass over to my colleague Yusuf, these are some of our findings and our recommendation on how you can build trust with migrants. Try not to introduce yourself as social prescriber at first, because the name social, it scares a lot of migrants away. Try to introduce yourself and do it in a simple way and what you can do to them. Don't ask about their immigration status if what you're trying to, the issue you're trying to solve with them is not relevant. If you want to solve anything with them, you don't need to ask them about their immigration status. Try using an interpreter or translator that can help those that are facing a language barrier to feel more confident. And consider meeting patients in the familiar or convenient places like children's centers or a pop-up clinic. And finally, try to give them examples of the service you can help them with, or you can provide for them to make them feel comfortable. Now I'm going to pass it over to my colleagues that will tell you more about the document. Thank you.
Brilliant. Thank you very much, Kemi. And just to say, everyone, that like these are really co-produced recommendations with migrants. And as you will remember from Claire's presentation, it is really essential that we build trust with migrants before we actually, continue to do our social prescribing. So that's why we wanted to kind of highlight these recommendations, but these are all in the materials. And I will now show an overview of the materials that we produce that can help you.
Yes. Could I just come in quickly on the subject of trust? Someone's asked a very good question about what the NHS's responsibility is to disclose if they're working with people who don't have immigration status. What's their obligation to share information about individuals with the Home Office? And I was wondering, I don't know the answer to that question. Does anybody here know that?
Oh, sorry, Yusuf.
Claire, you go first, because I think, you would be best positioned actually to explain this.
Yeah, so I just posted a link in the chat about a data sharing guidance that we agreed between Home Office, Department of Health and Public Health England about this, because we received a lot of questions about this, especially during the pandemic. And you'll see on that guidance that there's very specific wording about the two circumstances really in which data can be shared. One of them is related to charging and cost recovery when charges haven't been paid. And the other one is regarding safeguarding. So I would really encourage people to read that guidance. And in the toolkit that Kemi and Yusuf are talking about, there is a link to that section of guidance too. So if that changes, that's essentially where you would go to find updated information.
Thank you. I haven't ignored the other questions. I just thought that was very relevant to what you guys were talking about right now. Thanks, Claire. If you could put that in the chat, that'd be great. It's not coming up yet.
Perfect. Thank you. I think it was a very useful intervention, because it's really, this is something that we were considering, and we were quite cautious about like how actually we can establish trust. So you will see in the documents, we actually provided these recommendations alongside the data sharing agreement, all the information with links to the guidance that Claire has just mentioned. But let me actually just kind of provide an overview. So there are two documents. One is a poster that you can see on the right hand. This is just a one-page poster which includes all 9 recommendations we provided. This is something you can print, or you can use it, in your office. So just to remind you the recommendations, we will go through them quickly. And the other resource on the left is the toolkit itself, which is the longer document, like 20 pages or so, longer documents where you actually can find detailed information and links to further support, further resources and support available to support people. There are some shortened links here where you can directly, if you want to now, you can directly go and check this on your web browser. It's simply bit.ly SPLV poster or SPLV toolkit, so you can actually access these toolkits. So I'm gonna open the toolkit. I will open the poster now just to show the recommendations, a bit of an overview really. So we kind of put like 3 categories: what link workers we think should do before meeting, during meeting, and after meeting to help migrants to access healthcare. So before meeting, because we know that there was a lack of knowledge about the entitlements, which can be complex to some extent. We thought that, first a learning about entitlement and healthcare and the culture and health vulnerabilities that are associated with experience of migration would be a very good first step. You can see establishing non-GP referral pathways. We suggested this because we have heard from link workers that most referrals are actually coming from GP practices. And as Kemi showed, the barriers to GP practices, many migrants actually do not have access to GPs because of those barriers. So that means that actually migrants cannot actually access the social prescribing as well, because the referral pathways is mainly through GPs. So we suggested that if there is capacity, establishing this non-GP referral pathways, and there are sub-recommendations as well on this to help you out. Interpretation has been already covered, but we put some further resources that I will go through now. During meeting, explaining how the NHS works, because many people actually do not know the available services and which services are free. So they don't actually engage because they're not aware of it. So lots of resources and recommendations here as well. And there are two bits of important recommendations here: supporting GP registration and supporting migrants who may face NHS charges. Again, I'm going to talk about it in a few seconds now. The recommendation 7 is actually, broader support needs, which is actually social prescribing itself. So not about healthcare, but wider support. Is it legal advice? Is it how to kind of help them to apply asylum or housing advice, different kinds of support? And I've seen Justina has put actually a directory of organizations, which we also have a link in this document, which can be quite useful to actually find out which organizations in London are available and what they are doing in that. I'm going to show again about this. And after the meeting, it's just about really following up with patients, making sure they are happy with the service you provided, and then sharing good practice with others through platforms like this one, which is amazingly organized. And you will see a link to the toolkit. So because this is one-page poster, either using this QR code or the link, you can actually directly go to the toolkit to read more. So that's why we thought that this poster would be a good thing to print and put somewhere in your office or somewhere where you can actually see, and then you can actually always go and look at the toolkit as well. So looking at the toolkit, and you will see that Kemi, apart from leading the project, has been also featured in the cover of the resource. But it starts with an instruction on like how to use this toolkit. And I know there was a question like, how do you define migrants in the previous presentation? So it's a very broad term, but we know that as an inclusion health group, migrants who are in vulnerable circumstances are considered as an inclusion health group. So we provided definitions and understanding of what an asylum seeker, a refugee asylum seeker, a refugee is. As Claire rightly said, most of the time when we talk about migrants, it's often talking about asylum seekers and refugees, but actually there are other kinds of migrants who might need further help, like work visas, migrant with work visas with no recourse to public funds conditions, unaccompanied children, or people who might be trafficked to this country. So this is a bit of an introduction to understand different statuses, immigration statuses, and what might be relevant to their access to healthcare or entitlement to healthcare. So after this brief one-page introduction, you will see that 9 recommendations here listed again in the toolkit. I'm not going to go through them, but just to say that, for example, there are links here where you can easily navigate. But I'm just going to go through the document now. So 9 recommendations are here now. And the next thing is actually, you will see sub-recommendations or, further steps under each recommendation. So for example, the first one is equip yourself with information on migrants entitlement to healthcare. And if you scroll down and go to the next page, you will see that recommendation is here. And then you will see like, what are the steps that you should take to make sure you actually did this recommendation. So you will see some further recommendations and then further resources in a box. The second recommendation again in the next page, and then sub-recommendations and further resources in the box. So it all goes like this with all 9 recommendations. And then after those, we have a further information part, which actually explains more in detail about some of the important bits that we thought link workers should know. Well, the first one is actually the trust issues, which Kemi covered, and we've actually talked about that. And you will see, for example, data sharing agreement is here. Public Health England guidance is here with the link, but this is the latest version of the data sharing agreement, which actually explains in which situation data can be shared with the Home Office, which is quite useful for you to discuss if they are undocumented or refugee asylum seekers, or they may face charging at secondary care. And yeah, recommendations that co-produced with migrants that Kemi presented are also here. So the next point, for example, we thought health vulnerabilities experienced by migrants, health inequalities. So this is more like, what are the things? Why do they need to, access healthcare? And you can see actually how experiences of migration can actually lead to additional health needs, and also some systemic barriers that Kemi also covered as well are explained here. Another point here is actually entitlement to healthcare for migrants. And we divided this into two: entitlement to primary and entitlement to secondary care. First, talking about what are the rights and entitlements, and then secondly, giving you the steps really to actually support migrants to tackle those barriers. So everything you can do to register someone is actually written here. Available resources like GP access cards are available as well. And then we talk about secondary care, who might be charged, who might not be charged, which services are free, and who are exempted from charging, all included here, with links to the original guidance on migrant health guidance, and then practical tips on how you can support migrants who may face secondary care charges. For example, suggesting them to contact the NHS trust and agree a repayment plan if they've already sent a bill. And some trusts can actually write off the bill, but there might still be implications. So being aware of these things and talking to your migrant patient is essential. And the final further information part we put here is actually help with health costs, which is about the exemption certificates for medicine, eye and dental care, and also some travel to hospital. This is again not known much, but we put a lot of information here so that you can actually help migrants to actually apply for this scheme, to get the AC2 certificate or similar certificates like maternity exemption certificate as well, so that people can get the medicine for free, prescribed medicine for free. So these are the further information parts. So just a bit of an overview of like how to navigate the toolkit. As I said, like these 9 steps are here, and then you can click a step if you want to learn more. For example, recommendation number 5. You can read these steps here, what you need to do, and then if you want to read more about in detail, you can click and you can go to the further information part. You can read, and once you actually read that, you can go back to the content page and actually navigate it from here as well. I know there was a question, I think one of the participants said that about AC2 certificates. So as mentioned, information is here. This can be actually shared with GP practices as well, so that GPs don't refer based on this one, because this is like really general information. Available information is on the website as well. So all the information is useful, and you can share it with other health partners as well to improve awareness. So I guess that's enough for an overview, but we can see if there are any questions.
That's amazing. I was just going to say that's amazing. I think we can there's a few questions coming through, but I think we'll park the questions for now just to bring in Christine from Croydon, because I know that she is going to be Christine, sorry, I don't have so Christine is the head of operations at and sports at Croydon Voluntary Action Council. You've only got 5 minutes, so I'm not going to take up any more of your time. Do you want to introduce yourself, Christine?
Yeah, of course. Thank you for that. I'm Christine Double. I'm the Head of Operations and Sport at Croydon Voluntary Action, which is the community voluntary sector umbrella organisation in Croydon. And I think Justina asked me if I'd just talk about our project related to refugees and asylum seekers using sport as a tool for social integration. So I think it's one of the services that maybe the link workers would be referring people into. And to come back to Deborah's question, I think she mentioned a couple of times about duplication. I think it's really important that link workers know there are a number of projects, really great projects like ours going on already, and to link into you so you can make referrals and partner us on those organisations would be really, really helpful for us as well. It doesn't mean to say you have to do it all on your own, and then we'll bring in experts who can deal with some of the questions that you're asking in the chat as well. So just to tell you a little bit about our project, and also the reason I've got 5 minutes as well is I've got to shoot off to my, I've got a sports session starting, so I will need to go, and maybe I'll leave you with the video, which is actually done by one of our partners, Hillsong Church, and the Football United project. So I'll leave you with that after I've done my little bit here. So could you just go on to the next slide, please? So we run a project called We Stand Together, which is actually funded by the Mayor of London and Comic Relief. And as I mentioned, the aim of the programme was to use sport as a tool to improve social integration between refugees and asylum seekers and the wider community in Croydon. So we focus quite a lot on the initial hostels in Croydon. So when people come to the Home Office building in Croydon to register, when they first arrive, many of them go into initial accommodation hostels around Croydon. And our focus initially had been on there because we had a lot of people, particularly over the pandemic, who were in one room for long periods of time, couldn't get out anywhere and had nothing to do. So we were running a variety of different sports sessions, and my next slide in a minute will show the variety of sports, but we did start with football because football seemed to be the one that sort of brought the light to people's eyes when we started talking about it. So the other thing we've done is to work with refugees and asylum seekers to become the activators within that group. So we talk to them about what activities they would like to do, and then we give them support and training to help them decide what they want to do, where they want to do it, and how to deliver it as well. So we use the ABCD methodology, which I imagine a lot of you know about working with people's skills and passions and looking at what's strong within a community instead of what's wrong with a community, and we help them to find their own solutions. So over the project's just coming to an end now, although we've just got some extra funding coming from our mental health trust. We developed over 25 activators who run those sessions, and we've had over the participants over the 2.5 years. Well, considering a lot of that was in lockdown, was quite remarkable. And during lockdown, we did actually move some of our sessions online, which isn't always great with refugees and asylum seekers because of the problems of digital exclusion, which I'm sure you all know about. We also, at the same time, and I think this is really important when we come to the tips in a minute, we set up a steering group to help us deliver the project, and drew in a number of refugee led or refugee support organisations in Croydon, and that's really grown and it's taken on a life of its own. So we have about 120 members now and over 45 organisations as part of that forum, and at the moment obviously they're focused on the Afghan crisis situation and looking at how they can support refugee families coming into Croydon, and they've developed their own 5-point action plan. So here's just some pictures of activities we've done. A lot of these were focused on Refugee Week that happened this year in June. So we had about 20 different community partners supporting delivery of these different activities. And then we've been able to mainstream some of our refugees into those activities, although a lot of our refugees are more comfortable working within the activities that are mainly for them, because they get quite a lot of help and support in that process. And we did actually have access to Crystal Palace Stadium in June, at the end of June, where our refugee team played against a police team and a number of community teams, and that was the highlight of their year, I think. So Justina asked me also to talk about some of the top tips. Sorry, I'm racing through this now. So I guess the first one is to connect with other local community organisations who are working with your target group, and that'll be whatever target group you're working with. And then also with the other providers who can help you to deliver that service. So we work with local community sports deliverers who we know can deliver top quality sports provision, and we bring those partners together. We also, as I said, listen to people with lived experience, and we want refugees and asylum seekers to be an integral part of the project and listen to their voice and help them to deliver their solutions. And then trust has come up a number of times. I think Claire mentioned it first, and then Kemi mentioned it also. It's just really, really important with the people that are coming to us that we do build trust, both with the participants and our partners, so that they're comfortable referring people into our project. And we do this really by listening and responding, to respecting what people have got to say, by helping to tackle any barriers. So one of our big barriers that people often arrive on our programme with really just literally the shirt on their backs. So we've been able to get kit. We've had donations from professional football clubs, etc. So that's been really, really helpful. And I guess the last one is just to try to make sure you have fun and make sure that the participants have fun, because often for them it's an hour in their week that gives them an opportunity to forget the problems and challenges that they're experiencing at the moment. So yeah, I've run through that. I'm really sorry, I will have to go and not stay for questions, but I did put my email address in the chat. So if anybody wants to follow this up and talk to us further about our programme, I'm really happy to respond to you then. And I think I'll leave you with the video, hopefully.
I don't know whether or not we're going to have time for the video.
Okay, that's fine. That's no problem.
But thanks so much for joining us, Christine. That was really helpful.
Thank you.
Thanks so much. I'll let you introduce yourself.
Thank you. I did have a few slides, but I don't know if they're that important, really. Yeah, so I'm a social prescriber with One Westminster, and I'm based with a community mental health team in the borough. So I'm by no means an expert, but over the last year, kind of roughly half of the patients that I've worked with have been asylum seekers, refugees, or migrants. So I just kind of wanted to share some insight on the basis of that experience, really. So one of the things that I found kind of particularly helpful is having a basic understanding of the UK immigration and asylum system. And I think that's kind of helpful in determining the approach that I take to each case. So kind of, for example, learning that it's not unusual for an asylum seeker to be waiting over a year for a decision on their asylum application. And then kind of during that time, I would focus more on any support that might make managing this time period of uncertainty more manageable. Kind of another thing that I learned is that once an asylum application is granted, a person has 28 days to leave their asylum accommodation and to manage the transition from having no recourse to public funds to gaining full entitlements. So I guess in those cases, my focus would be more around kind of linking in with practical support and finding like a caseworker or someone to help with accessing benefits and that kind of thing. So on my slide, there was kind of a link to 2 resources that I found helpful, kind of one specifically around kind of the immigration system, and the second one kind of give it a bit more contextual information about the experiences of asylum seekers and refugees and the kind of challenges facing those communities. Yeah, so next, I'm lost with my slides. Next one. So yeah, as I mentioned, I think what I would focus on kind of changes according to the person's circumstances. And here I just collated some kind of key considerations that I would bear in mind for an initial triage with an asylum seeker. So kind of things like, does this person have access to legal support? Do they have kind of basics like food and warm clothing? Are they registered with the GP? Can they access health services? And also, are there any barriers there, kind of like language and things like that that we can support with? So next slide. So yeah, I just kind of collated some general advice on the basis of my experience. So one thing I think is important is to be mindful of cultural difference and the way that this can kind of shape your interactions with people. So for example, people can have very different ways of understanding and expressing mental distress, and it's good to be attuned to this. And we can also help people by referring to organisations that are sensitive to cultural difference, by kind of continuing to educate ourselves and kind of thinking about the way that we use things like language. Secondly, I think there are various different reasons why people can be anxious or hesitant about engaging with the social prescribing service. And I think this has been touched on by the other speakers, but I think it's about kind of being patient and very generous with your time and kind of building that relationship. And one of the ways of building a trusting relationship is by really taking the time to get to know the person that you're working with and kind of helping them to think about their strengths and work towards their goals, and I guess to kind of offer a genuine human connection. It makes me think of an example of someone that I worked with who was a young man who was really kind of very reserved and kind of would say that he doesn't like anybody, he doesn't want to speak with anybody, but he was kind of at imminent risk of becoming homeless. But kind of through being consistent and kind of nurturing that relationship, he eventually told me that he really wanted to be a football player and that he kind of previously played on a team, and that was kind of like my way in to supporting him. So yeah, I think kind of giving time to build those relationships. And then finally, I think it's important in order to be in the best place to support other people is being mindful of the impacts that kind of supporting others can have on your own mental well-being. So for me, I found it really valuable to speak with my colleagues and also attend like clinical supervision, just to share my own feelings. And I think also recognising the remit of your role. So I think there's a lot that we can offer as social prescribers, but equally I think it's important to recognise kind of people who've experienced complex trauma need specialist psychological support, and it's about kind of linking in with the most appropriate service. Next slide, please. Yeah, so I just wanted to kind of quickly give a bit of a case study. An example of someone that I've worked with. So I was referred a 27-year-old woman who had been sex trafficked into the UK. So she had an ongoing asylum claim and legal representation, but while she was waiting for a decision from the Home Office, she was living in a hotel and kind of spending all of her time alone in her room. So she approached her GP, kind of saying that she was experiencing low mood and difficulty sleeping and feeling anxious. Kind of spent that time getting to know her and finding out what was important to her, and she said it was her priority to learn English. So I kind of went along with her to a local college and helped her enroll on a class. Unfortunately, due to COVID, the class moved online, but thankfully I was able to apply for a tablet through a local charity so she could continue attending remotely. And also kind of really recognising the importance of that social contact. So I was able to connect her with like a conversational speaking group so she could practice using English with other people. And I got some really nice feedback from one of the organisers who kind of told me that she's become more confident over the weeks, and it's helped that there are other people in the group from the same country as her, so she has something in common and feels more at ease. She definitely volunteers to speak more and give it a go even when she's unsure of her language skills, and that she was a really great addition to the group. And as well as support with social integration, there were some more practical concerns around kind of the accommodation provided by the Home Office, and I was kind of able to support her with like getting a weekly food delivery. So I knew that she had like at least one hot, nutritious meal a week, but also kind of advocating for her and kind of other asylum seekers in that accommodation. So I spent time kind of collating information about people's experiences and raising those concerns with housing and local councillors, and kind of sharing with other third sector and kind of like faith networks in the borough so that we could create a wider picture of kind of what people's experiences were. Next slide, please. Yeah, so here's just a few kind of key organisations I've personally found helpful. And I think as link workers, one of the things that we can do is kind of emphasise gaps. So on that note, the Waterloo Community Counselling is currently closed to referrals. And kind of one thing that I've noticed is that mental health support is something that's kind of hard to come by for asylum seekers. And I think it's especially important in light of the fact that refugees are 5 times more likely to have mental health needs than the general UK population. And next slide. Yeah, so I just wanted to end by sharing this quote that I found from an actor from a film that's called Limbo, which is about the experience of refugees and asylum seekers in Britain. And he says that the term refugee is not enough to describe anything vaguely important about a person's character. And I guess I just wanted to emphasise that you can best support an individual by taking the time to find out what matters to them.
Oh, Sarah, that's absolutely brilliant. And I think it's made me feel a little bit emotional. I think that this is really important work supporting individuals who, I mean, you know, can you think of a better group of people that really benefit from being connected to all of the most important services out there? Link workers in the room, it would be great to hear from you about your thoughts on what Sarah's just presented. I mean, the case study was so helpful, I think, in talking about the various different ways that as link workers you guys can be supporting. I'm curious about kind of how many times, you know, what does the caseload look like for the other link workers that are out there? How long do you spend with people? That's to Sarah. Are you still there?
Sorry, could you repeat?
Oh, I was just going to say, what does the caseload look like? How many times are you likely to see people? The case study you gave, how many sessions would that have been?
Yeah, so with that particular young woman, I think it was a few months, and unfortunately, I guess it's the nature of working with asylum seekers, she was moved out of London into accommodation kind of elsewhere in the country, which was a shame, kind of not being able to follow her further on that journey. But yeah, I think it can vary quite a bit, really.
Link workers in the room, any comments or questions for other link workers that are doing this work? I came to Esther earlier, but I would love to come to her to find out a little bit more about the work that she's doing if we've got time. Would you be happy to share, Esther?
Yeah.
Esther was voted as our first star link worker, one of our first star link workers that goes out in the newsletter every month, and she has been doing some fantastically proactive stuff and really kind of embodying some of that community development that sits in the social prescribing role. I'll let you
thank you. Yeah, it's such a huge subject, isn't it? I don't know how much more I've got to add. It's probably helpful just to talk about some practicalities really of how it looks. Probably a bit like Sarah, been doing this the past year, and so how it looks when they kind of land in your area. So I'm in East London, and we had initial accommodation opened up literally on our street back in October, and then a pre-dispersal around the corner from the surgery at Christmas. I think it's probably fair to say you never get any warning, so you just hear it word of mouth. And I have to say as well, Doctors of the World, we couldn't do what we do without them. They've been so instrumental, so they're in there already, and they've really helped us. Some of the main things that have already been mentioned is helping these people to even know about the GP and where it is, and that they can access it. So practical things right at the beginning. And this is what we do. I'm not saying it's right for everybody, but a lot of what I do is outreach. So I will just go to the accommodation and say, so working with the accommodations and the managers, finding out the main languages spoken, and so doing a poster before we can do anything online. And then, like I say, Doctors of the World facilitate a lot of the online registration. That really helps us, and then we can pick up the rest. The toolkit is brilliant, and found that really user-friendly. I would just reiterate, I don't ever say social prescriber. I barely use that term now, because immediately, especially if it's being translated, they think social worker is what they first think, and they will stop talking to you. So we try and, as best we can, translate a kind of wellbeing, link worker, helper, supporter, all those things. I'm going to jump around a bit, but some of the things I was thinking is what is, and I think the lady Christine mentioned it from Croydon, just I feel that peer advocacy is what a lot of them need. So we need to you know, you make inroads into a place, and then them working with their peers to set up something lasting and something that they can trust. Referrals, quite often it's actually, we will get the doctor referrals, but that might be later on. So with some of the outreach we do, it's really helped. Doing a health clinic in our children's centre. So we have a health visitor that has the under fives, the mums and the under fives on her caseload in 2 of the accommodations, and now a 3rd one. So then I work with her as needs and with another doctor from his practice, and we set up just a pop-up clinic. The idea being just these people, they need a safe place. So actually a lot of the questions that Sarah put on the legal side, we wouldn't ask those. There is a time and place for that, but we try and do it as a health thing. So this is a health setting, so we're not going to ask you about your status. Well, what can we help you with? And the idea being as well, like Sarah said, people get moved very quickly and without notice. So we felt that certainly the families need to understand how a surgery works and that they can access it, and that there are children's centres where their children can get vitamins. They've remained open through COVID. Then from that, they might be given a family support worker if they're allowed around long enough. And it's a very uncertain science, but we feel that at least if they understand how it works, then when they get moved to the north of England and Sheffield, they know what to expect. And they meet someone like us. Again, the overlap thing, I think that Claire talked about, there's too many cooks, that does happen, that can happen. And because time is of the essence, so it's just really good communicating really with other professionals. So what we do here at the practice is we have well, in the borough, we have a fortnightly health asylum seeker operational meeting so that we can all talk about what we're doing. And so I work quite closely with the Care for Calais volunteers. Otherwise, we tend to be seeing the same people and they're asking us the same questions. So try and spread ourselves out a bit more equally. I think a few of you have mentioned just working with others. So all the different service providers. So like we have a food pantry, because actually there's a little bit of politics around asylum seekers aren't really supposed to go to food banks, but we realise we can bring food pantry items to them. It's just navigating that really, and sometimes that's outside. And probably lastly, I'll just say this thing of Claire mentioned at the beginning, but just creating your own, that's where you have lots of hats, because you're creating your own activities. The thing we've got in the pipeline, which is quite exciting, is another community centre that we're already doing an asylum kind of project, more for Bengali women, but now going to translate that into something we can do from the practice. We've had to just start somewhere, so it will be with women who do not need childcare. So when the kids go back in October, we'll do a 10-week. It'll be a language-based thing, but it's the wellbeing of language, we're calling it. So it's a lady that's done this before, and so the idea is, again, it's a safe place. It will just be the women. It will be gentle stretching with a bit of English thrown in, because quite often traditional ESOL is really hard for those that have experienced trauma to access or engage with. That's a bit of a whistle stop. Yeah, no, I hope that's helpful.
So brilliantly helpful. I think definitely I'm going to just bring back in a couple of other people for the last couple of questions. There's so much about what you're discussing that I think is so important. Social prescribing is supposed to be to support those. It's one of the ways that we should be tackling health inequalities, but we know that those that suffer from health inequalities are less likely to access primary care. So the fact that you're proactively going out there, knowing that there will be groups of people that can really benefit from your support, is so wonderful to hear. And I think that we are, I mean, I was on a meeting with One Westminster earlier in the week, and they'd had an email very late at night on Sunday to say that there were close to 200 people arriving with little more than an apple and a rug. and what could be done. And I think that social prescribers are going to be called on over the coming weeks and months in response to what's happening in other parts of the world. I'm curious about translation. We haven't really covered, what you might do if you're supporting people that don't have the language skills that are required to be able to engage in more of the in-depth work that a social prescriber can offer, and the perhaps some of the complexities when you have a family member that's doing that translation. I don't know if anybody that's got experience of working with this group want to speak to that or have a case study. Claire.
I can probably speak to that a little bit. I posted in the chat a little while ago. I can send a link again. So Public Health England, we worked with a number of different stakeholders, including the UK Institute for Translation and Interpreting, to produce some guidance for what language interpreting and translation should look like in healthcare, because we identified that it was a gap. There's not a lot of good documents out there. I think there might be one that NHS England produced for primary care, but we know it's not consistently done across the health and social care sector. And this issue of, using family and friends is often an issue when there may be, things hidden, like safeguarding concerns, where the person who's accompanying, an individual to a consultation might actually be in a coercive relationship with them, but you wouldn't know because language is a barrier. So there are lots of concerns with working with family members, and especially, we've talked about situations today where, trauma might be a factor as well, and actually working, sometimes children are also inappropriately used as interpreters, where, you think, oh, it's just easier to get, the child to interpret. But actually, when it comes to working with vulnerable migrant groups, that actually you're exposing that child to vicarious trauma as well, alongside. So we developed the guidance to try to cover some of these issues, and NHS Scotland actually really helpfully created a policy on this. I think it was earlier this year that we were able to use some of the materials from that to produce some practical guidance. So I'd really encourage you to have a look at that. It's quite new, so there may be tips and practical bits and pieces that might be useful when navigating language barriers.
Anything for the social prescribers to add there? What do social prescribers do when they're out there? I've done some research with migrant groups for hospital maternity services, and using the telephone services can be really slow, but I do think that it can be worth really persevering with, especially as you might catch somebody at exactly the right time to be able to engage and want to talk. I think, having volunteered in Calais myself for several months, the reason people are trying to get to the UK, or some people may not be coming through more official routes to land in the UK, are coming because they have family here. It would be really good to end on something around reunification. Someone put a really great question in the chat earlier. What services are there about reunifying people with their family that are already here? Again, I think a lot of people are doing this and not necessarily wanting it to be official. I think the response was that there is a service that the British Red Cross are using, but are there any examples from people in the audience that have gone through this process in the work that they're doing with their caseload? Who was suggesting that? Who's worked with the British? Who put the suggestion for the British Red Cross up? I can't see my.
Hello, this is Elizabeth.
Hi, Elizabeth.
Yes, hi. I'm the one who put the British Red Cross reference because I volunteered with them. As a legal officer after I left the UN, and they have a really excellent service that's computerized, and it doesn't put people at risk in terms of any information leaking through. But I would suggest, it's a year or so now since I worked with the Red Cross or volunteered with them. So I would recommend that people get in touch with the Red Cross directly. But they do global family reunification, not just sort of the Calais, or Mediterranean routes. Yeah, thank you.
Thank you, Elizabeth. For those of you still on, I'd really love to, if you could pop in the chat the services that you use that you find really useful. There is a directory of services. There is some stuff in the toolkit that's going to be shared. Obviously, all of this, the recording and the resources that have been mentioned today. I know that there's other things that are going to be in there. I think there's a letter that Esther's written, and some of the links that the speakers have spoken about today that will go in that resource pack. It's interesting that you mentioned about volunteering. The video we were going to show you earlier from Host Nation is an organisation that any link worker, I think they're working pan, is that right, Justina? They're working pan London. Do you want to just introduce them quickly? And then, so I'll just before Justina explains actually who they are, we'll end on showing the video of Host Nation as an organisation that are doing really fantastic work. After that, we'll close the session after that video. If anybody wants to hang around and have a bit more of an informal chat, then or to grab me or any of the speakers, then please do hang around, and we'll see if we can support. But thanks so much for today. I'll hand over to Justina, who can explain who Host Nation are, and we'll play the video.
Yeah, I will try to share my screen to play the video. Please let me know if you could see that.
Do you want to explain who Host Nation are?
Yeah, so Host Nation is an organisation offering befriending services to Londoners. So what they do is they match a refugee, asylum seeker, who is able to speak English, but needs a bit of direction and needs a friend in London. So they only provide befriending as their intervention, and they connect people. Rosanna, who works for Host Nations, really wanted to be with us today, but she couldn't, so she recorded a nice message for all of us to hear about Host Nation.
Hello everybody, my name is Rosanna Horsley. I'm from Host Nation, a befriending project for refugees and asylum seekers here in London. We work across London. I'm really sorry I can't be with you at this peer learning event. I would have loved to, but it's been impossible, so I'm doing it this way. Host Nation is a London-wide befriending project for socially isolated and lonely asylum seekers and refugees. We want to improve their lived experience in the city, help them feel that they're participating more and are more included, and also improve their English in a friendly and informal way. We match them with befrienders who live relatively close by on a one-to-one basis, and we ask for a 3-month commitment. People meet once a week, or if that's difficult, once a fortnight over that period, for a few hours each time. And we encourage people to, it's an active type of befriending. It isn't home visits, it's sort of going out and exploring the local parks, going to see sites that a refugee may have heard of but has never ventured to. And as I said, sort of in an informal way, perhaps sitting in a cafe and practicing their English without feeling self-conscious and gaining confidence in that way. It works really well for someone who is feeling lonely and isolated. Perhaps they know people in their own community, but they do not have any opportunity to meet a local person, a Londoner, who isn't someone who is, for whom they are part of some caseload, shall we say, a GP or a social worker or a therapist or a social prescriber. It's best for someone who is lonely and socially isolated, but feels curious and is keen to see and do more in London. They want to practice their English, and they are reasonably stable. And when we say that, we mean reasonably stable in their housing. They're not about to be sort of moved from their accommodation. They're not under threat of detention or deportation, and they are reasonably stable in their mental health. we can't take people who have high or complex mental health needs. If you look at our referral form, which is on our website, you will see we ask people, referrers to confirm a number of statements, and those are essentially our referral criteria. When we make a match, we introduce we first of all, we ring up the person who's been referred to us to have more of a chat with them, find out a bit more, get a sense of who they are, what are their interests, what they would like to do with a befriender. We then look for someone nearby, and we have to say one important thing is we never match a female refugee with a male volunteer. We look for, we consider geography, age, gender and interests. And when we think we've got a good match, we let the befriender know we think we've got someone, and when they're agreeable and so is the refugee, we introduce them. We do this on a short sort of WhatsApp call or a Zoom, and in which we also encourage them to make a plan. What would they like to do the very first time that they meet? And we check in after the first month with the befriender to make sure everything's going okay, find out what they've been doing, have they got any concerns or issues, and at any time the befriender can get in touch with the person who's made the match if they do have any things they want to discuss with us. And at the end of the 3 months, we get feedback from both sides. So we're constantly evaluating things. I have to say that 75% of our matches say that they want to carry on after the 3 months, that it's really worked for them. Because so we say we're an introductory service. This is an initial commitment people make, but they are adults and they can decide for themselves whether it's something that feels fruitful and positive and they want to carry on. And as I said, sort of 3/4 of them do. And quite a number of them also say that they feel they're developing a real friendship. When we've asked refugees, whether their English has improved, our most recent figures are sort of like 71% say yes, 88% feel less lonely, 86% feel more included, and generally 85% feel that their well-being has increased, it's been enhanced. And befrienders also get something out of it as well. I mean, although I know that we're talking now about the kinds of people that you would be referring to us, but befrienders find it's a really positive experience for them to learn from people who may be living very close by, but who they would not have met otherwise, if you like. And it is often a really good exchange. And we have seen some people really sort of be quite transformed by the experience. We have little films which will give you a bit of a feeling for the kinds of relationships that develop. On our website, on our stories page, you can see some accounts of the experience. I would just urge you, please, if you do think you have someone who you can refer to us, that you drop me a line just to tell me a little bit about them, why you think they would be suitable, and then I can get back to you and say, yes, go ahead, I think that's a good idea, or not. So I hope you find it all very informative, not just what you'll hear from me, but from everybody else. I think it's a great idea.
I had no anybody around me, to talk to, to give me that comfort I needed. And I met my wonderful friend, Helen. She's one of my dearest. So I'm so glad that I came to know Host Nation, because without knowing them, maybe I wouldn't have been able, to meet this wonderful friend of mine. You come into a new country, it's very hard to, walk out and speak to whoever you find. And through them, it makes it really easy for you to connect with the people, that help you to know more about where you live, know more what's happening in the country, so that you can get on. Everything is new to you, and you need that confidence, to be able to reach out.
Thank you so much to the speakers. You've been amazing.